Imagine suffering from severe, paralyzing depression. For decades, right, the standard medical answer has basically been, here's an SSRI, now just sit tight and endure a grueling, agonizing wait of maybe 6 weeks just to see if it even works. But what if we could compress that whole waiting game down to a single number? 2. Just 2 hours. That is the literally incredible onset time of this new class of rapid-acting drugs we're exploring today. So, welcome to this explainer. Today, we're diving deep into the fascinating neuroscience behind 2 wildly different molecules that just happen to knock on the exact same doorway in the brain to treat severe depression. We're talking about ketamine, a battlefield anesthetic from the 1960s, and nitrous oxide, the famous laughing gas synthesized way back in 1772. I mean, how do 2 ancient anesthetics completely outrace modern antidepressants? And, what are the hidden costs of all that speed?
Okay, let's dive into this. Here is our roadmap for today. 1. The glutamate doorway. 2. Mechanisms, cousins, not twins. 3. Speed and duration. 4. The clinical scoreboard. 5. Hazard curves. And finally, number 6, access in 2026.
All right, section 1, the glutamate doorway, blocking the receptor. Now, to really wrap our heads around how these molecules work, we actually have to totally leave the old serotonin model of depression behind.
For most of the 20th century, treating depression was all about nudging monoamines, right? Things like serotonin. But these 2 drugs, they skip that system entirely. Their shared identity is that they're both non-competitive NMDA-receptor antagonists. In plain English, they block the NMDA receptor's ion channel, slamming shut a central gateway for glutamate, which is your brain's main excitatory neurotransmitter. And here is where the neuroscience gets really counterintuitive. Blocking this excitatory receptor paradoxically causes a massive downstream surge in signaling that lifts mood. It's totally a paradox, shutting the door to create a surge.
Moving on to section 2, mechanisms. Cousins, not twins. Because while they share that exact same starting point at the NMDA receptor, their journeys through the brain diverge completely from there.
Let's follow this cascade, starting with ketamine's prevailing model, known as the disinhibition hypothesis. Step 1. It preferentially silences NMDA receptors on our inhibitory GABA interneurons. So, by basically taking the brakes off, we get step 2. A sharp surge of glutamate right in the prefrontal cortex. That surge then triggers step 3, the activation of a second receptor called AMPA. And that kicks off step 4, a whole biological cascade involving BDNF and mTOR that literally drives the rapid growth of new dendritic spines and synapses. It's actually rewiring the brain. Oh, and I should quickly note, there is this really compelling, though definitely contested, debate right now that a specific ketamine metabolite called HNK might actually bypass that whole NMDA step entirely to drive this AMPA activation. It's fascinating stuff.
By contrast, nitrous oxide relies on a multi-target approach. Sure, it shares that NMDA starting point, but it is so much messier in a really fascinating way. For instance, its painkilling effect actually runs heavily through the endogenous opioid system, triggering opioid peptides. It also weakly potentiates GABA-A, opens up specific potassium channels like TREC1 and SK2, and even touches dopaminergic reward pathways. So it's not just doing one neat thing. It's honestly more like a shotgun blast of neurochemical nudges.
And this brilliantly illustrates how entirely opposite their pharmacokinetics are. Ketamine is basically a metabolized marathon. It processes through your liver into active metabolites like norketamine and that HNK we mentioned, which stick around and act over several hours. But nitrous oxide? It boasts a blood gas coefficient of 0.47. To put that incredibly low number into perspective, it means it equilibrates in your brain in literal seconds, has almost zero metabolism, and gets exhaled completely unchanged. It is an instantly exhaled breath.
All right, section 3, speed and duration, route and experience. So, how does this invisible molecular dance translate into what the patient actually physically experiences? Well, ketamine is usually administered via an IV injection or a nasal spray. This produces a deeply immersive, hours-long detachment, which, at higher doses can totally tip into the intensely disorienting K-hole. Nitrous oxide, on the other hand, is inhaled, usually at a 25 to 50% concentration, and delivers a much milder, incredibly brief dissociative wave that just vanishes in minutes. But we have to talk about their shared fatal flaw here: poor durability. For both of these drugs, despite working their magic in just 2 hours, a single dose typically fades away within 1 to 2 weeks. Speed is absolutely their ultimate selling point, but lasting the distance, that's where both really struggle.
Which brings us to section 4, the clinical scoreboard, established versus upstart. Now I want to make it super clear right up front. This is a completely lopsided comparison.
We are looking at a firmly approved medicine versus an investigational upstart. Looking at the regulatory history, ketamine is absolutely the heavy hitter here. The esketamine nasal spray, Spravato, was FDA approved back in 2019. Fast forward to January 2025, and Spravato was actually approved as the very first standalone monotherapy for treatment-resistant depression. That's a huge deal. Nitrous oxide, meanwhile, is resting on a much smaller foundation. Peter Nagelli's crucial 2021 Phase 2 trial did prove that a lower 25% dose of nitrous oxide matched the benefits of a 50% dose, but with far less nausea. So it's an incredibly promising proof of concept for sure, but nitrous is simply not an approved psychiatric treatment yet.
Moving on to Section 5, Hazard Curves, Risks and Harms. Because these are incredibly powerful anesthetics, we absolutely have to examine their safety profiles.
We aren't crowning a winner here. Instead, we're neutrally examining two completely different sets of severe risks that accumulate in very different ways. Now, what's really interesting about this slide is how radically their harms diverge. Ketamine's risks really concentrate on chronic exposure. Heavy, sustained use causes severe, sometimes irreversible bladder toxicity, literally ulcerating the bladder walls over time, along with a real dependence liability and transient heart rate spikes. Nitrous oxide, on the other hand, is incredibly safe in supervised medical settings, but recreational misuse? Totally different story. Heavy recreational nitrous irreversibly oxidizes the cobalt atom in vitamin B12. This functionally inactivates the B12, causing your myelin to break down, which leads to subacute combined degeneration of the spinal cord and permanent nerve damage. Scary stuff.
And finally, Section 6, Access in 2026, Current Landscape. Knowing the incredible neuroscience, the clinical data, and those hazards, how do patients actually navigate this?
How do people access these substances right now, today, in 2026? So the crucial point here is the stark practical asymmetry between the two. Ketamine is a Schedule III legal medicine. You can get it in IV clinics, and thanks to a DEA extension running through the end of 2026, you can even access it via telehealth. Nitrous oxide, ironically enough, isn't a federally scheduled controlled substance at all, mostly because of its everyday culinary and industrial uses. Yet for consumers, it's facing a rapid crackdown. We're seeing FDA safety alerts targeting recreational brands and a growing patchwork of strict state bans. So you have this tightly regulated therapy with expanding clinical access up against a legal but increasingly restricted gas.
And that brings us perfectly back to our core premise from the source text. Same doorway, very different journeys. Choosing a rapid-acting pathway isn't just about finding the objectively best drug. It's entirely about patient fit, clinical monitoring, the timescale of the experience, and ultimately, accepting very different physiological costs to teach a depressed brain how to change.
Which leaves us with this final thought. We have two drugs that can completely shatter the old 6-week SSRI waiting game in merely 2 hours. Yet both struggle to make that relief last without maintenance, and both carry unique, severe hazards. So with distinct costs and shared durability limits, which rapid-acting pathway will ultimately define the future of mental health treatment? Will it be the metabolized injectable or the quick breath of gas? It is a truly fascinating scientific race to watch. Thanks so much for joining me on this explainer, and keep questioning what you know.